Tear troughs. They're the grooves or hollows just underneath your eyes and are a significant cosmetic concern for many people.
I was born with extremely dark hereditary dark circles.
The thing now is really the under eyes.
And it really bothered me because the makeup wasn't hiding it. The fact that I wouldn't feel confident without makeup on in this area.
It's no surprise that they are one of the most popular areas on the face to fill with dermal fillers. The idea of a simple, non-surgical procedure to fix what is often a lifelong concern can be alluring for both patients and practitioners. In fact, it took me 14 years of filling tear troughs from 2005 to 2019 before I came to the conclusion that I shouldn't be doing this treatment anymore. In this video, I wanted to share with you my journey and experience and provide you with expert opinions from Dr. Mobin Master, radiologist, Mr. Brian Mendelsohn, plastic surgeon, and Dr. Ben Burt, ocular plastic surgeon, to provide evidence and shed further light on the topic. I started filling tear troughs back in 2005. To be honest, the results over 14 years were varied and inconsistent. When I started, I probably didn't know what I was getting myself into. I used to put in large amounts of filler to show a difference and make patients happy at the end of a treatment.
With tear troughs, one syringe possibly per side in most cases now. And I find, especially with deeper ones, you need the full syringe.
Only to find that my patients would come back later with puffiness and overfilling as the filler hydrated. The nature of hyaluronic acid fillers is that they are hydrophilic. That is, they love water and attract many times their weight in water with time.
Then when he did it, I saw an immediate difference and it was crazy.
You can see instantly how it feels in.
What you see immediately after the injection is not a true result. This makes it hard to judge how much to put in at a time. The combination of the hydrophilic nature of hyaluronic acid fillers, the fine skin around the eyes that showed any filler imperfection, and patients that wanted perfection was, in hindsight, a recipe for disaster.
It never really got to a point where I really was satisfied with it. I had to go back a few times to get it sort of evened out, and this side was never looked the way that I wanted it to.
The past year, I started noticing these really harsh dimples forming underneath my eyes, and I spent the past 3 months going in again and again and again and again and again.
I persisted over the years, chasing that elusive, just right tear trough result. I tried filling tear troughs with smaller amounts, using less hydrophilic fillers, and modifying my techniques in using the use of cannulas rather than needles. Complications such as swelling or puffiness of the lower eyelid were still quite common despite these changes. I was always reassured by what we have been told about the longevity of hyaluronic acid fillers, which is that they only last for 6 to 18 months. So any complication should be resolved in that time frame, right? After several years of doing tear trough filler, I started to question this, as we had several cases where swelling or puffiness persisted for many years, well beyond the 6 to 18 months we were told that fillers last. Sometimes the puffiness occurred years after having what appeared to be a good result. Some patients had puffiness from filler for years without even realizing it was the filler, thinking it was just aging kicking in. To see if it was filler or maybe just fat pockets under the eye and aging causing puffiness, we started doing MRI scans on those with persistent swelling. Due to the hydrophilic nature of filler signal on MRI is white, similar to the signal for water, and its presence is clearly delineated on MRI. What we found was a real eye-opener. We had many cases where we saw filler lasting from 2 to 12 years on MRI. In this interview, I spoke to Dr. Mobin Master, who performed these MRI scans, about his findings. Good to see you. Thanks for coming in to share some of your invaluable insights with us.
Yes, good to see you again, Gavin. Always a pleasure.
Thank you, thank you. So this is the man, a radiologist and a cosmetic physician. He is a guy I send to when I need to see stuff beneath the skin. So he's like the answer book. He gives us all the answers. And I think there's been some huge insights recently in the past year or two, where we've done some MRI scans of patients, and you've found a lot of interesting things.
Very interesting stuff. As you mentioned on the previous longevity interview that we did together, and that actually kind of changed the face of injectables pretty much. It has really changed the way I
It's
inject,
changed my practice too, yeah.
the way you practice as well, and many other injectors. So the paper in Plastic and Reconstructive Surgery of America was accepted, and it's currently released, and it's on paperback in January 2021, and it describes 14 patients, and we showed that many patients had filler still there after 2 years.
Yep.
One of them was 12 years, and there was still hyaluronic acid filler in the tear trough or in the orbital area.
And I believe out of that study, out of 10 patients who had fillers more than 2 years ago, all 10 showed?
All the ones that had a question of do they have filler over 2 years, all of them had filler.
100%.
Yeah.
Isn't that amazing? That's just blowing me
It's
away.
a small...
One might argue that even if fillers do hang around for many years, they are fully reversible with injections of the enzyme hyaluronidase. I used that as my justification for continuing with performing tear trough filler, until I had a case of lower eyelid swelling that I just couldn't dissolve. Again, Dr. Mobin Master reveals how this happened. Just over a year ago, I had a patient which I sent to you, and it was a really difficult patient, and she had fillers done in her tear trough, and she had this persistent swelling which just wouldn't go away. And we dissolved it with a bucket load of dissolving or hyaluronidase, and it just wouldn't go away. And I was so puzzled, and I sent it to you. Maybe you can tell us a bit about what we found.
She was a fascinating case, actually, and you sent her to me, and I thought, well, how are we going to work this out? And you said, well, why don't you do an MR? So we did an MRI, and we found that yes, there was filler in the tear trough area, which is quite typical, and it shows that bright signal on T2, which demonstrates the filler located in the tear trough area. But it also showed post-septal filler, meaning that it was underneath the globe. So it had somehow got under the globe. And since then, we've had another 2 cases of that, and we can discuss the treatment.
That is phenomenal. So maybe you can explain to the viewers what the orbital septum is, and what it means to go through that and go underneath the globe, or the eyeball, basically. Just explain, why was this patient so difficult?
So the orbital septum is actually a division beneath the eyelid that separates the globe and the intraocular, or in the eye, the actual eye area underneath your actual eyeball. So you've got a septum at the bottom and you've got a septum at the top. And for example, if you've got a really bad infection, we always talk about, has it gone post-septal? Because that's dangerous, because it means it's gone underneath the globe. So it's a barrier. It's basically a very fine film barrier, and I think it's finer than we think.
So a needle or cannula could penetrate it pretty easy without knowing.
That's right.
Potentially.
And one of the cases was, I think the case that you had sent me was a cannula, and the other, I think one other case from elsewhere was a cannula and one with a needle.
Okay, there you go. But this MRI that you did explains why we had such a hard time dissolving it. So maybe you can explain, why it was so hard and what was done to actually alleviate that filler.
So clinically, what you do is you get the needle and you inject where the puffiness is, right?
Yep, that's what we do. Yep.
So generally, that's a logical point of call, and you were trying to inject and go, okay, why is this not going away? The septum, though, is underneath the globe, and not in a million years, I don't think an injector would have thought it has gone under the eyeball. And you're probably, without ultrasound vision, you probably wouldn't be willing to stick a needle under the eyeball, would you?
That's why we had problems, because we never stuck the needle under the eyeball. So
that's right.
I left that to my friend here, Mobin. So tell us what you did.
What I did is I get an ultrasound probe, and you're running a needle underneath the ultrasound probe where you can actually see it. So it has to be directly parallel to that probe. And I could see the globe, and I knew where the filler was, but I couldn't, it was kind of semi-blind, i.e. I couldn't actually see that post-septal filler, but I knew I was directly underneath the globe. So I used the MRI like a map. So it's like a map in front of me. So I was looking at that going, okay, it's under the eyeball, probably dead center. And then what I did is I used the ultrasound to make sure that my needle didn't touch the globe.
Okay.
So I'm within a few millimeters of the actual eyeball.
Wow.
And then squirted it, and then we did an MRI afterwards, which showed that it had resolved, and it got rid of the filler underneath the eyeball.
So, we must have tried about 7 times to dissolve this just without ultrasound guidance or MRI. And it really took your expertise to do this. And I'd imagine that in the world, there are not many people who actually have done this sort of dissolving. I could imagine, you'd be one of the few.
Yeah, I haven't heard of anyone doing dissolving underneath the globe.
And since then, this first case where we've had this post-septal filler, you've had a few others present?
Yeah, we have had a few others. And, while we're talking about that, there's a picture you can see there of the before and after the post-septal filler was dissolved, and you can see a little crease under her eye has come back, meaning that it's less puffy.
Yep.
So we did get, majority of the resolution in that case. Another 2 cases did come to me, and I MR'd these patients. I didn't expect it. And these 2 patients had post-septal. One of them had an injection 12 years ago.
Wow, there you go.
She said she was puffy immediately after the injection, and often this is the problem. You're puffy immediately after the injection, and then you wait for it to resolve, but then it never resolves. So I think it was in the post-septal or underneath the eyeball from the start. So we MR'd her, and I did exactly the same process, the same pathway.
Given fillers can last a very long time and also have the potential to be injected post-septally or under the eyeball, I needed to make sure that there was an appropriate basis for treating tear troughs with fillers. I started researching this, and I found the answer was right under my nose. I found in 2012, Mr. Brian Mendelsohn published an article titled "The Tear Trough Ligament, Anatomical Basis for the Tear Trough Deformity." Unfortunately, the cosmetic world didn't heed the warning contained in this paper that is almost now a decade old. In this paper, through dissection of 24 cadaveric faces, he found a true osteocutaneous ligament attaching skin to bone in the tear trough. That is, the skin of the tear trough groove is tethered to the bone underneath by a ligament, which means you can't lift it with filler. It's anchored down. It's like the buttons of a mattress, pulling the mattress down. You can't lift these buttons by stuffing more foam or padding underneath them. You can see this when you are squinting. The orbicularis oculi muscle that surrounds the eye moves except for the tear trough where it is tethered down to. Many attempts to find an anatomical basis for the tear trough have been made in the past, with no prior studies finding a tear trough ligament. Mendelsohn states that the discrepancy was from the dissection approach used in previous attempts. Basically, there's been a lot of hypotheses about why there's this hollow trough there, and multiple surgeons or anatomists or doctors have tried to find this a ligament there and been unsuccessful. So maybe you can tell us why, what made your study successful. How did you find it when others had failed?
Well, so often with anatomy, it's the way you dissect. And all surgeons know that. One day you dissect a few millimeters to the side and you see the structures differently from what you're used to seeing. But fundamentally, surgeons dissect by layers, and they lift off the skin, then they lift the orbicularis, and then they go down to the layer 3, where the ligaments may be. And they couldn't see it. And the reason that they couldn't see it is because the ligament extends between the dermis and the bone. And as soon as you take the top layer off, the ligament loses all its structure.
Mendelsohn's anatomical approach found the elusive tear trough ligament that hadn't been found previously and helped explain the reason why filler simply can't lift the tear trough groove that is held down by this ligament. In his publication, Mendelsohn's conclusion was that filler can be placed underneath the tear trough ligament to support it, but should not be placed above or directly into the tear trough, as this can aggravate the deformity. Given its tough fibrous nature, I feel that filling directly over or in the tear trough ligament commonly leads to extrusion of filler to either sides of the ligament, which causes puffiness in the lower eyelid. The technique suggested by Mendelsohn of placing filler underneath the tear trough ligament, essentially in the cheek, has become my go-to method for consistently improving the tear trough groove through support of the ligament. I never fill over the tear trough groove or ligament now. To see if a patient will benefit from this supportive filler, I perform a simple press test on the cheek. If there is improvement in the tear trough from the test, then it is likely that filler in the mid-cheek under the tear trough ligament will help. Patient expectations are paramount here, and it's important to explain prior that it may not completely remove the tear trough groove, only soften it, and that further improvement may require surgical correction. Surgery should also be presented as an option for anyone presenting with concerns about their tear trough to provide a more balanced view, even though the prospect of surgery may be scarier than a few injections. I spoke to Ben Burt, oculoplastic surgeon, about the surgical options for tear troughs. I'd like to introduce Dr. Ben Burt, who is an oculoplastic surgeon, and he is very well known for his work with lower eyelids in particular. Firstly, what sort of people are you seeing come in for lower eyelid surgery? When would you say it's time to have surgery now?
I think there's two big groups. So there's one group that I would almost say are congenital in terms of their tear trough deformity. And those people always have noticed that feature. Even when you look at photos of them as a child, maybe one of their parents has it as well, usually one does. And they've never liked that appearance, and they've always waited to have something done about it.
So these patients are really quite young. So it's not necessarily like an older sort of patient. They can come in their 20s, say, for example?
Yes, even teens. So
even teens, yeah.
Probably once, twice a year see someone who is so sure they want surgery and their parents know about it, they're unhappy about it, and they just wait till they're about 18, maybe leaving school, that group. And then there's the more acquired group where they're a little bit older and they just age in a certain way that creates a bag and a very firm trough underneath the bag.
Right. So tell us about what you do with that tear trough ligament in surgery. I mean, how do you detach? You literally detach it.
It's detached. So I go a transconjunctival approach. So the patient's always asleep. My assistant's retracting the eyelid forward, gone through the conjunctiva, through the retractor down to the periosteum. So I'm literally looking at the periosteum, and then I'll either incise it directly with a sharp edge of a freer periosteal elevator, or even with a diathermy just to get onto the bone. Certainly that's a robust way to lift that area, and to, as we heard earlier about the anatomy, to elevate the attachment, one of the attachments of that ligament.
I mean, when you say, even just saying those words, it makes me think back on all those patients I've done where we're trying to lift this tear trough, hollow, with filler, and they've got literally this tear trough attached to bone, which is attached then to their skin, and here we are trying to lift it up with a very sort of soft filler, and that's probably one of the reasons why we've had so many issues. In conclusion, given the potential longevity of hyaluronic acid fillers, the risk of inadvertent injection of filler under the eyeball, and the anatomical basis for the presence of the tear trough, the use of filler in the tear trough needs to be questioned. Filler injected into the tear trough commonly results in complications and regret. As doctors, we take on board the Hippocratic Oath, which is first, do no harm, and given the likelihood of potential problems that tear trough filler can cause, we must consider our oath in this situation. I hope the lesson that took me 14 years to learn and the production of this video will have a positive effect in helping to educate people out there about the potential dangers of filling the tear trough region.